Breast reconstruction. What are your options? Welcome to Talking with Docs. I'm Dr. Brad Mooney.
And I'm Dr. Paul Zalzal.
I'm Lauren Willoughby.
Dr. Willoughby is an expert in breast reconstruction, and she is going to guide us through this discussion and actually do the discussion. We'll just listen. First of all, what's the difference between a breast reconstruction and a breast augmentation?
It's a good question, and it's something to explain clearly kind of off the bat. So breast reconstruction means a surgery where you're attempting to make a breast after a woman has had part of their breast removed, which is a lumpectomy, or all of the breast, which is a mastectomy, generally for breast cancer. Cosmetic surgery, which breast augmentation would be a type of, is done when you have a woman who has normal anatomy and they're trying to seek some cosmetic ideal that society says you should have.
Okay, there's a very good distinction between those two, reconstruction versus augmentation. And today we're going to talk about breast reconstruction.
So Lauren, is this always someone who's had cancer?
So not always. So most of the time it is. And so women who have had cancer need surgery.
Right.
Either you remove a part of the breast, which is a lumpectomy, or you remove all of the breast, which is a mastectomy. Some women, though, will be offered mastectomies prophylactically, which means they don't have breast cancer, but they might have a really high risk of developing breast cancer due to their family history, or they might have a known genetic mutation, such as the BRCA mutations.
And this would be something that would require a lot of planning and thoughtful consideration between the family doctor, potentially a geneticist, and then the surgeon and the patient.
That's right,
Okay.
yeah.
Okay, cool. And now we're going to focus on what happens after that. So you've had either a lumpectomy or a mastectomy, and you are interested in some form of reconstruction. So what are the options? First of all, what's the difference? How do you approach, as a cosmetic or plastic surgeon, how do you approach a lumpectomy situation versus a mastectomy situation?
So generally it'll be the general surgeon that drives what happens. So so the most common way of removing a breast cancer is a lumpectomy.
Okay.
And often the general surgeons will do this without involving a plastic surgeon. However, if they need to remove a large portion of the breast and they're worried it's going to leave a deformity, they might involve the plastic surgeon right off the bat. So that's sort of one way it can take, and that approach is generally called oncoplastic surgery.
And when that happens, is that at the exact same time?
Correct.
Right,
yes.
so you guys would come in together, or the general surgeon would call you and say, hey, can you come in once we've removed the lump, and then you come in and reconstruct?
That's right.
Okay.
Generally, we mark the patient together too.
Okay.
I love that team approach.
Yeah. So ideally, we in plastic surgery see the patient well before the surgery so that we can come up with a plan, make sure we have a plan depending on how things go, a plan A, a plan B. If a patient is having a mastectomy, the best way to reconstruct the breast is, again, at the same time as the mastectomy because it has a few advantages. The main one being you can preserve the skin envelope of the breast. So you might be able to keep the nipple. There are some cosmetic and some oncologic or cancer-related reasons why you might choose to or not choose to. But you get to preserve that envelope. And also then the patient doesn't have to go flat for a period of time. So it's called an immediate reconstruction, and that's the gold standard when you build the breast at the same time as the mastectomy. A delayed reconstruction is when the woman goes flat for a period of time. Then they see the plastic surgeon afterward, and then they're offered a reconstruction.
Okay, so something important to know is that the amount of tissue that's removed is determined by the cancer and by the pathologist. That's how you decide how much tissue has to be removed to safely be confident that you've cured the cancer. And then whatever's left, that's how you make that decision. And sometimes that's made at the time.
Yeah, generally we know if we're doing a lumpectomy or a mastectomy,
Right.
but yes, it's one of the first things that sort of decide which pathway you're going down.
Got it.
Okay, and so lumpectomy, on the other hand, is often done by the general surgeon, and then the plastic surgeon is involved after.
That's usually the way it goes with the
Okay.
lumpectomy.
Okay, so let's say someone's had a lumpectomy, it's a significant amount of tissue that's been removed, and they approach you and say, okay, I'm interested in some kind of reconstruction after this lumpectomy. What does that road look like?
So it depends what the problem is.
Okay.
So if sometimes a breast that's had a lumpectomy can get a deformity. And in general, breasts look funny if the shape is funny or if the nipple position is off. So you kind of have to break it down into those two components. So if the nipple position is off, you have to ask yourself, can you reposition the nipple?
Right.
If there's a dent, how can you add tissue to the dent? So you might do fat grafting, for example, which is a technique where you harvest fat from somewhere and you inject it into the dent. Or you might take a larger piece of tissue from somewhere else on the body and rotate it in, and those are called flaps. You also have to think about the other breast too, because sometimes even though the breast has had a lumpectomy, the aesthetics might be good, but then it just doesn't match the other breast. So you might consider reducing or lifting the other breast to match. And what's great is in Ontario, the government funds a balancing procedure for the other breast as well.
Oh, excellent.
Okay, so this might vary depending on what region you live in. We're fortunate to live in a place where that reconstruction is covered by our provincial insurance plan.
Yes.
Which is good to know. People might be wondering about that, especially in Ontario. Okay, so that's the lumpectomy route. Now for mastectomy, reconstruction after that, what are the options there and what does that road look like?
So in general, when you're building an entire breast, there's two pathways. Either use an implant or use the patient's own tissue. And there's pros and cons to each. So in broad categories, implants, most women are candidates for implants with some exceptions. The main advantage of implants is that the recovery from surgery is faster because there's only one surgical site, which is the breast. If you're making an entire breast from the patient's own tissue, there are a few places you might go, the most common being the abdominal tissue. And there's a technique called a DIEP flap, D-I-E-P. It's kind of like a tummy tuck. Of course, it doesn't have all the bells and whistles of a tummy tuck. Like we don't do liposuction and all that stuff. But you take that lower abdominal tissue, you bring it up to the breast, and you reattach the blood vessels. Another way is to take the tissue from the back, a latissimus dorsi flap. And then there are other reconstructions where you can take thigh tissue, buttock tissue, etc.
And just for our viewers, we're not just talking about skin and fat. We're talking about muscle and vessels and...
Some of them have muscle and some of them are fat only.
Right.
Okay, so
Skin.
that's a reconstruction using tissue from another part of your body, moving it to the breast to reconstruct after mastectomy. And then you mentioned the other option was implants. Okay, and what are these implants made of? What's the road look like if you're getting an implant?
So there are different types of implants, silicone and saline. So all breast implants have a silicone shell. And the material that fills it is either saline or silicone. And in breast reconstruction, and even in breast augmentation too, we usually use silicone implants. It just feels softer, looks a bit more natural, and ripples less, which means that, maybe if we can take a look at an implant. So thank you so much. This is a breast implant. So all implants ripple to some degree. So when it's inside, anyway, so saline is salt water, so it ripples a lot. These are silicone implants, so they ripple a bit less, and they all will ripple to some degree, but it just feels a bit more natural. So in reconstruction, that matters a lot because there's no breast gland anymore, so it's just the implant making the shape of the breast mound. You might have a skin envelope on top, you might put it behind the pectoralis muscle, but anyway, there's a very thin layer supporting it. When a woman has had a cosmetic augmentation, it's very different. They still have a breast gland on top, so you don't see all those ripples as much.
Sorry, so is that a saline one? No,
They're all silicone.
These are all silicone, okay, so
Yeah.
they're not rippling. A saline one, you'd actually just, you mean ripple, like you'd see a
These
wave?
ones ripple a bit too, and they've
Okay.
made different thicknesses
Oh, I
of
see.
gels to try to
I see.
combat
Just
that,
understand.
but
Okay.
yeah, they all do to some degree.
Okay, so any risks with having an implant? I mean, we put in tons of implants. That's our line of work. We put in simple machines in people, right? Hip replacements, knee replacements. These are made of metal, plastic, which sound like they'd cause much bigger reaction than something that doesn't move around much. But are there any risks or complications that can happen with breast implants?
Yeah, so I generally say implants are safe, but yes, they can have complications, like any devices you were mentioning. So what are those complications? The two ones in reconstruction that we really worry about that can be serious and cause you to lose the reconstruction are infection or wound healing problems. So the risk of infection is low, it's less than 5%. But if an implant gets infected, same thing for you guys in orthopedic surgery, it's a big problem. So with a breast implant, often you have to remove the device if you can't control it.
And we've talked about this before on our channel, that when you have something that doesn't have an inherent blood supply, bacteria can attach it, and then our bodies have a less effective way to clear it. So sometimes antibiotics can be used, sometimes simply washing out there can be used, but often you can't get to those tiny little bacteria at the back or wherever, so it has to come out in order to cure the infection, which is very disappointing for the surgeon as well as for the patient. I think that's one thing to take home. When this happens, your surgeon is devastated for you, and it happens, but it's so difficult to deal with.
The other important thing is that complication is rare.
Yes.
It happens in orthopedics, or anytime you have an implant put in your body, there's a risk of infection. But luckily and miraculously, that risk of infection is very, very low. That doesn't matter if it happened to you. You don't care how low the risk is because it happened to you. But in general, if you're considering this, the risk is low. Now, things like infection, wound complications, and those risks can happen with just about any surgery that we talked about already as well.
But more commonly, I guess, for your procedures, because you're disrupting the native field, and then they may have even had something like radiation, which really compromises the blood supply. So it's all about blood supply.
Yes, it is. Yeah. So I guess other complications, so wound healing problems, as we mentioned. The body responds to the breast implant like it does any implant by making a scar layer around it. And for the breast, we call that the capsule or the implant capsule. And sometimes, usually it's a nice thin layer, but sometimes that layer can get thick and squeeze the implant, and that can make it feel firm or change the shape, and that's called a capsular contracture. Again, the risk isn't high, 5 to 10% depending on the study that you read, but it can result in the need for another surgery. Sometimes the implant position shifts a little bit on the chest wall over time. That's called malposition. Implants can rupture. If they rupture, they should be replaced. And there are two very, very, very rare cancers associated with implants that we always tell patients about, even though the risk is 1 in many, many, many thousands. One is a type of lymphoma called ALCL, and it's found only in devices that have a textured surface, or patients who have had a history of a textured surface of their implant inside, but the risk even in those patients is really small, and we don't use those implants anymore. And the other is a rare type of squamous cell cancer, the risk probably being 1 in hundreds of thousands. This was recently described by the FDA.
Okay, and that's probably really scary for someone who's thinking of having this done for reconstruction, because the whole reason you're here is because of cancer, and now you're hearing, oh, well, I'm going to treat you with something that carries with it a risk of cancer. But like Dr. Willoughby said, that risk is very, 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 very small.
That's right.
Okay.
Long term, is there any specific kind of maintenance or follow-up that's required for people that do have breast reconstruction?
Yeah, so in general, the patient gets seen several times in the early postoperative period, make sure everything's healing okay. But in general, it takes many months, if not a year, for everything to settle. So in general, patients would be seen about a year as well after surgery. And at that point, you decide if you need to see the patient further, if they need touch-ups. And sometimes these patients just like being seen, and I'm personally always happy to offer them follow-up appointments long-term, just to ensure that they're still happy, see if they need any revisions in the future.
Awesome.
All right, that's anything else that you can think of, or did we cover it, or did you cover it pretty well? I can take any credit here.
I'd say it can be overwhelming for patients when they meet a plastic surgeon, or if patients read things online about all the options for reconstruction. There's a lot of options, and it's tempting to think that you know what you want, but there are lots of factors that have to be considered. Like, are you going to have radiation? Have you had surgery on your abdomen before? How much surgery can you recover from? Do you have someone at home who can help you after surgery? All of these things play a role into deciding what option is best for you, whether it's implants or using your own tissue. And again, there's pros and cons to both approaches. So just lean on your plastic surgeon, ask them whatever you want, and you want to have that rapport with someone who can explain things to you and you feel comfortable.
On the off chance that someone feels not comfortable making the decision for reconstruction right after because they are overwhelmed, which is probably not uncommon, and say 6 months or a year down the road, they're like, man, I really regret not getting reconstruction right away. Do I still have that option as well?
Absolutely.
Oh, okay, so that's good to know.
You can always do a delayed reconstruction.
Right.
Yeah.
Ideally, you would say it's at the same time, but it's not contraindicated or anything like that.
That's right.
Okay, good to know.
The ship has not sailed.
That's right.
All right. Well, Dr. Willoughby, thank you so much. I think this is a very useful video for people who are in this situation. And we really appreciate you taking the time to make this video with us.
Great. Thanks for having me and talking about this important topic.
Now you're more educated. If you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
We'll see you next time.